Welcome back to everyone after your coffees. I hope you've all perked up a bit. We did actually touch on the care pathway and PBC yesterday. So I spoke with Rob and said, well, we've spoken about all of this. And he suggested that what we do today is touch on the current care pathway, but really start to think about what the care pathway might look like in the coming months and years. And I think it would be helpful, actually, rather than just me talking at you, if we made it fairly interactive. So if there are any questions, raise your hand, and we'll get a microphone over to you, ask your questions, and we'll just make it a bit of a discussion rather than a lecture. So yes, so the oh, great. Fine. For people to be able to hear me there. So these are the topics for discussion. We'll talk about how we approach therapy in PBC, as in how we think about it, the current approach to care, and we'll just be looking at the BSG guidelines, the care model based on the current BSG guidelines. Talk about treatment targets again, and why we might be revising those in future. Look at stratified primary therapy, and I'll explain what that means when we get to that point, and then just have a little think about the newer medications and where they might fit into the care pathway and where people might want them to fit into the care pathway. So firstly, the disease process in PBC. Yesterday, we talked about what causes PBC, and you might remember that I said that it is what's known as a complex disorder, also known as multifactorial, also known as a polygenic disease, which means that people have a genetic predisposition, and then at some point in their lives, they're exposed to one or more environmental triggers, and PBC develops thereafter. But we can also think about the disease process in PBC, how PBC moves from that initiation of autoimmunity all the way through to an actual liver disease. And if we're thinking about the disease process, then we might think that there is this, just looking at this diagram here, that there's this initial autoimmune liver injury, very early in the stage of disease, which affects the bile ducts. Slowly over the course of time, the bile ducts become more and more injured. And as a result of that, you develop something known as cholestasis, which means an impairment of bile flow. The bile isn't flowing nicely out of the liver. A lot of bile is becoming trapped inside the liver, and that leads to a second injury called a cholestatic liver injury, because bile is a very toxic substance. And slowly but surely over time, that leads to fibrosis and scarring of the liver. And eventually, once a great deal of scarring has taken place and the liver has become cirrhotic, the liver begins to fail. And the reason that's all relevant is because if you're trying to design treatments for PBC, then you might want to target either that initial immune-related injury, which damages the bile ducts, or you might want to target this cholestatic liver injury, that secondary cholestatic liver injury, or you might want to target fibrosis, or you might want to treat the liver failure. But the treatment of liver failure is liver transplantation, and by and large, that's exactly what we're trying to avoid. Okay. Now, of course, all of these things have been tried. So if you happen to be very, very bored one day and you start looking through the literature, a very long literature in PBC, then you'll discover that a lot of trials have been done of immunosuppressant medications in PBC, and sadly, all of them have failed. People have looked at steroids for PBC. No really successful trials there. Azathioprine for PBC, methotrexate for PBC, colchicine for PBC. You know, a whole host of studies have been done looking at immunosuppression or immunoregulation in PBC, and by and large, those trials have been unsuccessful. As I said, you might then focus on that cholestatic liver injury, and in fact, that's where all of the trials, all the successful trials have been done. So ursodeoxycholic acid treats the cholestasis. Obeticholic acid treats the cholestasis. Bezafibrate treats the cholestasis, and so on and so forth. So a lot of successful trials of bile acid therapy. So far, no antifibrotic therapies have been successful. And as I said before, we're by and large trying to avoid liver transplantation. Okay, so when you're trying to design a care pathway for PBC, these are the sorts of things that you're thinking about. This is a very fiddly slide, but I do want to show it to you because these different pathways become relevant as we speak. I said to you that PBC leads to damage to the bile ducts. The damage to the bile ducts leads to impairment of bile flow, known as cholestasis. And that cholestasis, that retention of bile inside the liver, causes that secondary cholestatic liver injury. And I also said that all of the successful treatments so far are bile acid therapies. So it's worth knowing a little bit about the formation and flow of bile. The first thing to say is that the formation of bile, summarized by this figure here, is an extremely complicated process. There are many, many proteins and molecules involved, but the ones to know about, partly because I'm going to mention them a great deal in the next 20 minutes, the ones to know about are two molecules called FXR and PPAR, all right, both central in bile acid metabolism, and both of which reduce the synthesis of bile acids, but increase the flow of bile. Okay, so they overcome that problem with cholestasis and bile acid retention inside the liver. And then the other important molecule to mention, increasingly important, is this molecule called the ileal bile acid transporter. And the reason it's important is because you may recall from yesterday's discussion that your liver makes bile. That bile then flows from the liver through the bile ducts into the intestine. It flows down in the intestine, doing a lot of good work, aiding with fat metabolism and so on and so forth. And because bile acids are quite useful molecules in the body, you've got the system in the end of the small bowel, the ileum, to take up some bile acids using this molecule here called the ileal bile acid transporter, to take that up the bile acids and recirculate them to the liver so that they can do a little bit more good work inside the body. And that we call the enterohepatic circulation. Okay, so just three molecules to remember for the next 20 minutes. FXR and PPAR, which reduce the synthesis of bile acids but increase bile flow, and IBAT, the ileal bile acid transporter, which is part of this enterohepatic circulation of bile. Okay, and that's as much biology as we need to know, but it will be relevant. Okay, so this is the care pathway, and we'll just walk our way through this again. Remember, if anything is confusing, just put up your hands and we'll sort of linger on it for a little bit longer. But we touched on this yesterday, but just to rehearse it, the first thing we have to do is make this diagnosis of PBC, okay? And that diagnosis, as we talked about yesterday, is broadly speaking based on abnormal liver blood tests, presence of anti-mitochondrial antibody, and in some people, a liver biopsy. Once we've made the diagnosis of PBC, the current approach is these three pillars of care, okay? Firstly, treatment and risk stratification. Everybody starts treatment with ursodeoxycholic acid. Just to remind you, everyone receives or should be receiving the ursodeoxycholic acid at a dose of 13 to 15 milligram per kilogram per day. We wait about 12 months and have a look at the blood test to see what the biochemical response to the ursodeoxycholic acid is. If there is an adequate response, we stick with urso. And if there is an inadequate response, then that case is discussed with a multidisciplinary team, so a team of experts, to decide what second-line treatments might be suitable. And the current second-line treatments that we use in the UK are obeticholic acid and bezafibrate. Next pillar is this one, stage and survey. So we appreciate that with the best will in the world, some people will have progressive liver disease. And that means that at intervals, somewhere between every 1 to 3 years, we need to reassess the situation, reassess the stage of the liver disease to see whether that person has developed cirrhosis. And if that person has developed cirrhosis, then we start some additional monitoring, for example, regular ultrasound scans, close monitoring for liver failure. And if liver failure supervenes, then we need to think about liver transplantation. Okay, and then the final pillar is actively manage, and that is actively manage symptoms such as itching, symptoms such as fatigue, It's the sicker symptoms and complications or associations such as osteoporosis. Does that all make sense? Very good. Okay, and this is where it gets a little bit more technical. So apologies for that, but I will walk you through all of these slides. I just wanted to show you how do we reach the point of offering people second-line treatment with obeticholic acid or bezafibrate. Okay. Now the first is how do we reach the point of offering obeticholic acid? That was based on this study called the POISE trial, which was the gold standard, a randomized controlled trial in which there were 217 people with PBC who either had inadequate URSO response or who didn't tolerate URSO. And those people received either obeticholic acid or they received placebo. Those people were treated for a year, and at the end of that year, their blood tests were analyzed to see whether they had achieved what they called the primary outcome, or we call the primary outcome, which was in this case an alkaline phosphatase less than 1.67 times the upper limit of normal. Okay, and you can see from this graph here, particularly this bit here, that at the end of 1 year's worth of treatment, about 50% of people who had been treated with the obeticholic acid had that reduction in alkaline phosphatase, but only around 10% of people who were receiving placebo had that reduction in alkaline phosphatase. So that's quite convincing that the treatment with obeticholic acid will improve the liver biochemistry. Would you be convinced by that chart? Good. Because the FDA was also convinced by that chart. Following the POISE trial, the company that makes obeticholic acid, Intercept, submitted their data to the Food and Drug Administration in the US. And on the 27th of May, obeticholic acid was approved. And I put down their approval statement here because I just wanted to mention this issue, which we touched on yesterday, which is that the indication was approved under accelerated approval based on reduction in alkaline phosphatase. And of course, that makes sense because you just saw the chart. The study was done to show improvement in alkaline phosphatase. They showed improvement in alkaline phosphatase, and therefore they received this accelerated approval based on that improvement in alkaline phosphatase. That all makes sense. But note this follow-on statement: continued approval for this indication may be contingent upon verification and description of clinical benefit in confirmatory trials, meaning that it's not good enough to just show improvement in the liver blood tests. You also have to show that that translates in due course into improvement in survival. It's only worth taking the drug if it makes you live longer. Otherwise, if it doesn't, then the improvement in the blood test is purely cosmetic. Does that make sense? Yeah. So the company went on and they put together this follow-on trial, which was designed to demonstrate that improvement in survival. And this is the big issue of the moment. That trial, unfortunately, was unsuccessful, not because the drug doesn't work. It was unsuccessful because it was impossible to recruit enough people with the disease in that trial. And it's a big issue in PBC because PBC is a rare disease. And it's also a slow-moving disease, and it's really hard to put those sorts of trials together. There is another way of gathering the data, though, and that's to look at what we call real-world evidence. What real-world evidence means is that you treat people with obeticholic acid. You'll have a whole load of people in the community who have not received obeticholic acid, either now or historically. And if you put the data together in a very careful and methodical way, then you can make a comparison between people who have received obeticholic acid in the community through commercial means, okay? You can compare those people to people who are exactly the same in every which way, except that they didn't receive the obeticholic acid, all right? And when that has been done, and it has been done, you can see that actually people who received obeticholic acid have a better survival than people who don't. Okay, so just to explain this in a little bit more detail, this is what's known as, so this is a Kaplan-Meier curve, is its technical term. It's based on survival analysis. Okay, so you're analyzing survival in one group versus another. And this is what's known as a survival curve. And it basically shows the rate at which people drop off, sadly, as a result of clinical events. You know, hepatic decompensation, needing a transplant, or potentially dying from liver disease. You can see here the blue line is the group of people treated with obeticholic acid, and they didn't drop off because the line is flat, right? They carried on surviving. You can see here the red line, though, where people are dropping off as a result of complications from liver disease. And the key point is that those lines separate. Okay, we call that a divergence in the survival curves. And that demonstrates that treatment with obeticholic acid, when you look at people from the real world, is effective. All right. And the big controversy at the moment is, well, how do you convince regulators that this is real? All right. The next drug we use is this medication called bezafibrate. Bezafibrate works on that PPAR molecule. You may recall my mentioning it. So it reduces the synthesis of bile acids. It increases the flow of bile. And a study was done in 2018 called the Besurso trial, in which 100 people with PBC who had inadequate response to ursodeoxycholic acid were treated with either bezafibrate or with placebo. And after 2 years worth of treatment, their blood tests were analyzed to see whether they had met the primary outcome, which was normal liver tests. Okay, so what you can see here from this bar chart is at the end of 2 years worth of treatment, about a third of people treated with bezafibrate had achieved normal liver blood tests, compared to none of the people who had received placebo. So you can see from that that the bezafibrate was considerably more effective at normalizing the liver blood tests than placebo. Again, are you convinced by that evidence? Good, okay. Same issue though, it's not good enough to simply show that a medication reduces the blood tests. You also have to find some evidence that it improves survival. No one has attempted to do a formal clinical trial of survival under treatment with bezafibrate, but people have looked at real-world evidence. Okay, so they have compared people receiving bezafibrate in the real world, compared them to very similar people who have not received bezafibrate in the real world. Okay, and you can see here the survival curves in those groups. So you can see that the people receiving bezafibrate have much better survival than the people who are not receiving the bezafibrate. All right. So we would say that here again, there is real world evidence that bezafibrate is effective at improving survival. All right. Same issue though, we have to find some way of convincing regulators that this real world evidence is true. Does that all make sense so far? Good. Okay, so now the next point of that pathway is just to remind you, when in the current care pathway, everyone receives treatment with ursodeoxycholic acid. We then wait 12 months, and at the end of 12 months, we have a look at the liver blood tests, and if the liver blood tests are not if the alkaline phosphatase has not achieved a certain level, then we think about second-line treatment. What is that current level? 217, absolutely right. Yes, it's 1.67 times the upper limit of normal. So in the UK, that's the sort of threshold that we look for before we consider a second-line treatment. Now, I showed you these graphs yesterday, and I just want to show you again because it is an important issue. These graphs come from a study by a chap called Lammers et al. 10 years ago, the study was done, but it's still a very important one. They did a survival analysis of 4,500 people with PBC who'd been followed up for many, many years. Okay, and what they showed very clearly, demonstrated by these graphs here, is that the higher the alkaline phosphatase, the greater the risk of having a complication from PBC. Okay, and it doesn't just start at 1.67 times the upper limit of normal. It's any elevation above normal is associated with that slightly higher risk of a complication from PBC. So these are important charts, and the take-home message, of course, is, well, why are we using this 1.67 threshold then to decide if somebody needs second-line therapy? Shouldn't we really be thinking about normal liver tests? Now, that has been looked at in a little bit more detail, actually. There is this one study published this year from a team in France in which they did survival analysis in 1,000 people with PBC who actually had very good biochemistries already. They already had an alkaline phosphatase less than 1.5 times the upper limit of normal. And when they divide that group of people into different levels, what they discovered is that people who have normal liver biochemistry, completely normal liver biochemistry on treatment with ursodeoxycholic acid, have better survival than people who have abnormal liver biochemistry on treatment with ursodeoxycholic acid, all right, even when the alkaline phosphatase isn't all that elevated. Okay, does that make sense? So taking the alkaline phosphatase down from around 1.5 times the upper limit of normal to normal improved survival. So you might immediately think, okay, well, surely that, then is obvious. Surely we should just be aiming for an alkaline phosphatase that is normal. Yes and no. What they actually discovered when they really dipped into the data was that improvement in survival was mainly in people who had advanced liver disease, so they already had at least moderate scarring of the liver, or they were that much younger, aged less than 62. If people were older than 62 and they didn't have advanced scarring of the liver, then really you didn't see much of an improvement in their survival. Okay, so it does give us an idea that, that we should probably be aiming for normal, but perhaps we should be aiming for normal in a particular group of people, those who've got a bit more scarring of the liver and younger patients. Any questions related to that? Yeah.
Okay, I'm going to be as respectful as possible when I ask this question. So when you look at the older group who do have scarring, normalizing the bloods didn't make that much of a difference in their longevity of life. So how much is not enough to go for it?
Well, no, these are very important questions. This is only one study,
Yeah.
and we probably need more studies like this to try and work that out. I don't think anyone would ever say absolutely no, but and this is a very important discussion, actually, so we can probably spend a little bit of time on this. Remember that when a physician is deciding what to recommend, and bear in mind, physicians only recommend, they don't decide, they don't force people to have treatments. When physicians are deciding what they ought to be recommending, they're taking a number of different factors into account. Let's think about the current treatments that are available and how we would apply those current treatments to this situation now. Okay, so our current options are obeticholic acid. It is a good treatment, but it does worsen itch, particularly in people who have already got bad itching. It shouldn't really be used in anybody who's got very advanced liver disease. So if there's any evidence of hepatic decompensation, that drug is already a no-no. And there is some suggestion that it shouldn't really be used in anybody who's already got clinically significant portal hypertension. So that means that we've already limited that drug to a group of people. And if it so happened that it was a person who was older than 62, who did have clinically significant portal hypertension, you probably wouldn't want to offer that person obeticholic acid for fear that you would give them worse symptoms and that you would potentially make their liver disease worse. Consider also bezafibrate. Bezafibrate, again, very good drug. We've seen it. The charts show that that drug is effective. But it can worsen renal impairment. You shouldn't really be using it if the GFR, the estimated glomerular filtration rate, which is a measure of kidney function, if that is less than 60. Who are the people who tend to have a glomerular filtration rate less than 60? Well, it's older people, I'm afraid. Our kidneys get old and tired as we get old and tired. So, you know, that again, would we want to offer bezafibrate to somebody aged 75 with an EGFR of 55 in the hopes of improving their PBC, but by the way, knackering their kidneys? We wouldn't. So it's a little bit complicated. Of course, if a drug were invented tomorrow which had no side effects at all, then we would offer it to everybody. But there are very few drugs that do, and therefore it becomes a bit of a balance between the pros and the cons, and therefore you do need to know that you're going to make a really significant difference when using a drug that comes with side effects before you actually offer it. Does that make sense? Yeah.
Excuse me, I had a quick question if I can.
Yeah.
Raised levels of alkaline phosphatase, aren't they correlated to mitochondrial dysfunction? So in older people, perhaps the dysfunction is gone on too long for them to respond to any treatments.
Yeah, I'm not sure about that actually. Certainly in terms of why does the alkaline phosphatase go up, that's it's induced by cholestasis, is the thought to be the mechanism. And the cholestasis that happens in PBC happens as a result of several different processes, cellular stress from reactive oxygen species, apoptosis, etc. It doesn't necessarily happen from mitochondrial dysfunction, although mitochondrial dysfunction is undoubtedly part of a cellular stress response. So I'm not sure it's necessarily linked to that. We don't actually see older people with PBC don't invariably have higher alkaline phosphatase. In fact, it's often the opposite. Is often the case that it's younger people with PBC who have more difficult disease and have higher alkaline phosphatase. So I'm not sure that even the relationship between mitochondrial dysfunction, age, and alkaline phosphatase necessarily holds. Okay, so that's the that's the first question: is should we be aiming for a lower alkaline phosphatase before we initiate to prompt initiation of second-line treatment, and hopefully, prompted by Robert's question, hopefully you understand the slight dilemma that we have in offering treatment at a lower level. The second question, of course, is, well, why wait 12 months? It's actually possible to predict with a reasonable degree of accuracy who is and who isn't going to have adequate improvement in their blood tests with ursodeoxycholic acid. You can predict that from baseline. So the current model seems a little bit disingenuous. If we can already predict at diagnosis who is not going to achieve an alkaline phosphatase less than 1.67 times the upper limit of normal, why not just crack on with second-line treatment from that point? And we don't know whether that would in fact improve outcomes in PBC. So there is a study at the moment called Optimizing Primary Therapy in Primary Biliary Cholangitis, the OPERA trial, which is designed to address exactly that question. So, quick bit of audience participation. If your PBC was diagnosed yesterday and you hadn't yet started your ursodeoxycholic acid, and if we could predict based on your diagnostic blood tests that you were unlikely to achieve that alkaline phosphatase less than 217, the current threshold, would you want to receive enhanced therapy, second-line treatment from day one? You would, yeah. Okay, good. So there's a good reason to do this trial. Then we'll plug away at it so that we can answer exactly this question. Okay. Fine, so that's where we are at the moment, all right? Everyone receives urso, blood tests after a year, alkaline phosphatase greater than 1.67, offered obeticholic acid or bezafibrate. It doesn't work in everybody, though. You already saw from the charts that obeticholic acid only achieved an alk phos less than 1.67 times upper limit normal in about half of people. You also saw that in the BEZOSO study, the bezafibrate only normalized the liver tests in about a third of people. Okay, so our current treatment options don't work for everybody, and therefore it is very important that we have other medications on the horizon. And the good news is that we do. Okay, so this is the ELATIVE study. This is a slide from the ELATIVE study, which was published in the New England Journal this year. In this trial, 161 people with PBC who had inadequate urso response or intolerance of ursodeoxycholic acid were treated with a new drug called elafibranor or placebo. And they were looking at improvement in the alkaline phosphatase after 52 weeks of treatment. Okay, and you can see here from the charts that after 52 weeks of treatment with either elafibranor or with placebo, that again, about half of people receiving the elafibranor achieved that outcome, improvement in the alkaline phosphatase, compared to only 4% of people who received placebo. Okay. And about, what is that? That's about 15% of people who received elafibranor actually normalized their liver biochemistry after 52 weeks of treatment, compared to none receiving placebo. So again, does that convince you that this drug is doing some good inside the liver? Yeah, good. Now, the other exciting thing about this, though, is that it also resulted in an improvement in itching. So this little graph here shows itch measurements using a numeric rating scale in the people who received the elafibranor in the yellow, okay, compared to the itch measurements in the people who were receiving placebo in the gray. There was an improvement in those people, in the people who received placebo. That often happens. You do get a placebo effect whenever you're looking at itching, but there was really a convincing greater improvement in itching with the elafibranor. So this is really nice, that this is a drug which not only improves the liver biochemistry, but actually improves one of the really important symptoms of PBC as well. So on the back of that, the makers of elafibranor submitted this to the Food and Drug Administration in the US, and they got their approval on the 10th of June. So this drug, elafibranor, indicated for treatment of PBC in combination with urso in those who have an inadequate urso response or people who are intolerant of urso. Again, though, just to highlight, this indication is approved under accelerated approval based on reduction in alkaline phosphatase. Continued approval is contingent on further evidence of survival benefit. All right, so we're going to have to be really careful with this drug and what we do with it and how we monitor its use to make sure that we are able, in a few years' time, to provide the evidence that it improves survival so that the FDA doesn't withdraw this approval, but gives full approval. Okay, now again, a bit of audience participation. If you were offered elafibranor because you needed it, okay, and knowing the importance of having real world evidence in due course that the drug actually works, would you sign up to a registry that would enable the NHS or whoever else to monitor your liver tests, what happens to the PBC, and show in due course that the drug works? Yeah, okay, well, that's good, because I'm sure that someone's going to be approaching you about that. Yeah. Good. Okay. Now we can't just depend on one drug. You know, we need an entire armory of drugs. And again, this year there was another study published called the RESPONSE study. In the RESPONSE trial, 193 people with inadequate urso response or urso intolerance were treated with a drug called seladelpar or placebo. Again, they looked at the same endpoint as the other studies have looked at. They looked at improvement in the alkaline phosphatase below this magical threshold, 1.67 times the upper limit of normal after 12 months of treatment. Here's the main chart from the study. You can see here that 61% of people who received seladelpar had that improvement in the alkaline phosphatase, compared to only 20% of people who received the placebo. And 25% of people who received seladelpar had complete normalization of their alkaline phosphatase, compared to none of the people receiving placebo. Okay, so again, does this convince you that the drug is actually working? Yeah, it convinces us all. And once again, you know, good news here as well. Seladelpar also seems to improve itching. This is again measures of itch based on numeric rating scale. Here's the placebo effect. So you do see some improvement in itch in the people who are receiving placebo, but here's the drug effect. Okay, substantial improvement in itching in people who receive seladelpar. So once again, here's another drug which improves the liver biochemistry and improves one of the major symptoms of PBC. So these are, you know, these are really exciting drugs to have on the horizon. They've also got their FDA approval, but once again, I'm just going to highlight the FDA has approved it under the accelerated approval program based on reduction in alkaline phosphatase. Continued approval may be contingent upon verification and description of clinical benefit in confirmatory trials. So it's the same issue. Anyone who receives seladelpar should also think about whether they're willing to sign up to some kind of registry so that, you know, 5 years' time, we're able to show that the drug really helped. Okay, various other trials on the go. Yeah.
You mentioned a registry in 5 years. Is that the kind of time frame that is involved here? Is that the time frame of what's already just happened? What is the scope of where something might need to be monitored and measured?
Well, I mean, I say 5 years because PBC itself is a relatively slow-moving disease. So if we were to take a group of people today who were eligible to receive treatment with elafibranor or seladelpar, and we would compare them to a group of people from, say, 10 years ago who were exactly the same in every which way, but there was no seladelpar or elafibranor to offer, then it would probably take 5 years worth of follow-up to begin to see the differences in outcomes of those two populations of people. Well, if it's very carefully designed, we hope so. The FDA has, as we discussed yesterday, published a document in which they describe the level of evidence needed. It is very, very rigorous, as you would expect, but there is such a thing as a real-world program, real-world evidence program. So, is provided the registry is carefully designed and the information is collected in a very methodical way, then we would anticipate that they would. Okay, so so just back to this pathway.
Hi, please could I ask, there's a lot of talk between the alkaline phosphatase and the OCA. My alkaline phosphatase is almost normal, but I've been put on OCA for AST. What's the correlation between OCA and AST, please?
Well, yeah, it's an interesting question. I mean, in fact, OCA didn't look at transaminases as an outcome measure. So it's quite difficult, I think, to give you an answer with respect to obeticholic acid. But some of the newer studies have looked at the importance of transaminases and the improvement in transaminases. Improvement in transaminases does appear to translate to a long-term clinical benefit. And I guess from that evidence, we could probably say that, you know, improving your AST is going to provide some benefit. But usually the decisions related to obeticholic acid are based on the alkaline phosphatase. Right, so I just wanted to come back to this actually, because the question really, and I'm not going to have an answer to this, but the question is going to be, well, how will these new drugs, which will be commercially available in the UK pretty soon and will be available via the NHS shortly thereafter, the question will be, well, how are they going to fit into this particular pathway? And the answer is that we don't yet know. That's going to require quite a lot of discussion with NHS England, with NICE, who funds these drugs, with the CRG, the Clinical Reference Group, which advises NHS England, and so on. But they will be added to this care pathway so that if people have inadequate OSA response, we begin to try to decide whether those people should be receiving obeticholic acid, fibrates, elafibranor, and seladelpar. And it's probably going to be, the decision is probably going to be based on things like the stage of the liver disease, the presence of symptoms, the presence of other conditions, including kidney injury, and so on. Okay, does that make sense? Of course, it's not just about disease modification. Symptoms are also important. We've had a good session this morning on the importance of managing symptoms such as fatigue, and the management of symptoms is part of the current care pathway. The current guidelines offer us this advice for the management of itching. So everybody with itch will be offered Questran in the first instance. Not the nicest drug, but it is effective in a lot of people. And if the Questran isn't effective, or it's simply unpalatable, then the usual next step would be rifampicin. Rifampicin is, again, a very effective drug, but we do have some reservations about using it, especially in people who've got advanced liver disease. So once again, we need some new drugs. It looks like seladelpar and elafibranor might help with that problem because they'll fix the disease as well as fixing the symptom, but they won't solve it completely. So we still need new medications for treatment of itching. And the first piece of good news is that fibrates might be helpful. This is a study called the Fitch study, which was published in 2021. In this study, 74 people with moderate or severe itching from their PBC or other liver diseases were treated with bezafibrate. Bezafibrate is a drug that we currently use for treatment of PBC, for the disease itself, or placebo. In the study, the primary endpoint was 50% reduction in itching after 3 weeks of treatment. And you can see here the effect of the bezafibrate versus the placebo. Almost half of people on bezafibrate achieved this improvement in itching, okay, compared to only 11% of people who received placebo. All right, so that's good news, and it does mean that actually, if we see people with itching, especially people who have got active liver disease, then we might say, well, look, if the ALK Phos is elevated and you've got itching, then probably the best drug to try is bezafibrate rather than a obeticholic acid. Does that make sense? Good. Okay. Yeah.
My husband has given me permission to ask this question, and he's the one with PBC, not me. The reason that he is looking to avoid cholestyramine is not so much that it's a bit unpleasant to take, but that it, forgive me, I'm just about to go a bit off piste here, but it does produce rather bog blocking turds, right? He was quite impressive before, but adding the cholestyramine.
I'll write a book about it, you know.
Adding the cholestyramine has really generated, and it's a quality of life issue. For example, it makes him anxious to not use toilets in places where he might have literally blocked the toilet in a public place and feel embarrassed about that. So I mean, it's a quality of life issue. So we're looking to try and avoid cholestyramine, and Dr. Gish, who's one of the experts who is on the panel of people who appear in the videos on the PBC question and answer sessions on Facebook, has a sheet of alternative treatments for the itch, and top of the list for him is primrose oil. So we're currently trying that, but there's two issues with that. One is that he recommends a dosage in grams, which is not, I don't know how you translate that to milliliters. But the other thing, I was just curious if anyone else was trying that, or whether you had an opinion about primrose oil as being an alternative before we then move down the other more standard medical recommendations.
I've not heard of primrose oil being effective, actually. But you know, different physicians have different experience, and I wouldn't particularly in this forum recommend that, because, you know, strictly speaking, if I'm standing on the stage, I should be offering you advice about evidence-based treatments, and there is no evidence that would support the use of primrose oil. I think if you're looking for a medication, then I guess the next step, based on our guidelines, would be rifampicin. However, the bezafibrate is already used in PBC. It does appear, based on the Fitch trial, to be also effective for the treatment of symptoms, and therefore that might be a good alternative. Yeah. Okay. So I guess you know, in a clinical setting, we would currently therefore move on to rifampicin. But that's in part because I'm standing on a stage speaking to a lot of patients, and I'm on a webinar, and I'm not best placed to really offer any advice about non-evidence-based treatments. Yeah. Yeah. Okay, so just the final thing, actually, because we don't really need to touch on fatigue after such a great session this morning, and that is just back to this slide about formation and flow of bile. And I just wanted to highlight this again, which is the enterohepatic circulation of bile acids. So just to remind you, the liver makes bile, the bile flows down the bile ducts into the intestine, flows all the way down the intestine, and then the bile acids, or a large proportion of them, are taken up by this this molecule called IBAT, the ileal bile acid transporter. Bile acids might be involved in causing itch. We don't really have a fantastic understanding about who gets itch and why, but it does seem to make sense that bile acids might be involved in causing itch. So a whole bunch of clever people have often thought, well, if we interrupt that enterohepatic circulation of bile acids by, for example, blocking this receptor, the ileal bile acid transporter, then maybe there would be an improvement in itching. And you heard about these drugs yesterday, actually. You heard about linerixibat, and I think you might have also heard, inappropriately, about volixibat. But these are IBAT inhibitors, which interrupt the enterohepatic circulation of bile acids, and they do seem to work, actually. This study called Glimmer was published last year, 2023, and it described a trial in which 147 patients had been treated with different doses of a drug called linerixibat, this IBAT inhibitor, okay, compared to placebo. A very complicated study design, so I won't go into any of the details, but in their per protocol analysis, which is a particular way of analyzing the data, they did see a significant reduction in itching in the people who had received the linerixibat compared to the people who had received placebo. And you can see that broadly from the charts, but this is probably the most convincing one. Green is the linerixibat, yellow is the people who receive placebo. Okay, so these IBAT inhibitors look as though they do a fantastic job for itching, and they'll be a really important addition to the armory of treatments that are available. Not going to go through fatigue because we've had a really excellent session on fatigue this morning. No medications are effective, but it sounds as though exercise-based therapy may well be the answer. Okay, so those are the topics we've discussed.
Excuse me.
Yeah.
I'm on the Glimmer trial.
Mm-hmm.
Started it at the very beginning about 8 years ago. After the second phase, we had COVID, so we didn't carry on with it. And now we're 3 years into the third phase. I didn't have any real help with it until 2 years in. And now I will definitely say that my itch is really getting very much better. But the lady I turn up with, once we started on the, the final drug, to tell people she stopped itching in 6 weeks. So it's a fantastic drug.
Yeah. Well, that's good, and that's what the evidence would suggest. I mean, there is a follow-up study called Listen, which hopefully will show something very similar. Yeah. Okay. So, any final questions before we all move on to the next session?
There'll be more questions later on.
Mhm.
Okay, perfect. All right, thank you, sir. Okay, so George will be back after lunch in terms of working on Project 1990 and what we're going to be doing in the future. And again, there will be an opportunity to ask George's questions. So, ladies and gents, George, thank you.